Good afternoon, everyone. Welcome. I want you to know that from my perspective, today is a very special day. We have the Bob Schreier Lectureship today. Bob was a previous chair of medicine here at the University of Colorado, really helped build the Department of Medicine from a small department to a very large, nationally prominent department with lots of NIH funding, with a full academic set of accomplishments and goals, and with faculty that are superb that Bob Anderson and I inherited and have had the pleasure of working with. So today we have the Bob Schreier Lectureship, and it's a pleasure for me to introduce Rick Johnson to you, who is the division head of renal diseases and hypertension, who will introduce the lectureship and introduce the lecturer.
Thanks. Yeah, we're very happy. Our renal division is very happy to have this Schreier Lectureship. Bob Schreier is a nephrologist and also was the chairman of medicine. He ran the division of nephrology for like 20 years and the Department of Medicine for 26 years. He is world famous for his work in the area of fluid and electrolytes, vasopressin, acute renal failure. But he also was a leader in American medicine and was president of most societies. He published over 1,000 papers, and he unfortunately can't be here today. He's now retired and was unable to come. But we are honoring him with this lectureship. It's in the 6th year. We did get support from it from Amgen. We want to thank Amgen for it. Today's lecture is Dr. Sharon Anderson, who's also a leader in American medicine. She's well known as a leader for women in academic medicine. And interestingly, she's had many areas of contribution in the science of nephrology. One of her great research breakthroughs was the discovery that diabetic nephropathy is associated with glomerular hypertension, and that it can be protected with ACE inhibitors. And a lot of our what we do today with treatment of diabetic nephropathy largely goes back to her work when she was with Brenner at the Brigham. For the last number of years, she's been quite a few years. She's been at Oregon, at the University of Oregon, where she is currently the chairman of medicine, and is also, continues to have impact in nephrology. She was the president of our society, American Society of Nephrology, just a few years ago. So her main interest now, besides running the Department of Medicine, is in the area of geriatric medicine and geriatric nephrology. And her lecture today is going to be on should we dialyze grandma, and it's really a great honor to have Sharon Anderson here to give the Schreier Lectureship. So Sharon.
Thank you.
Thank you for that very kind introduction. I am very honored to be here to be the Robert Schreier Lecturer this year. I first met Dr. Schreier many years ago when I was applying for renal fellowships. I interviewed here. At that time, I was incredibly impressed with the program. And at that time, as ever since, it's been one of the leading programs in our country. I ended up not going here because I really wanted to go back to the East Coast. So I went to the Brigham, and that worked out okay. But I've had a great respect and friendship for the members of the nephrology division here ever since. So as I said, I'm extremely honored to be here to do this. So my topic today relates to dilemmas in the management of kidney disease in the older patient, and I really could subtitle it, the technologic imperative versus the moral imperative. We have a lot of challenges in how to best take care of our older patients with chronic kidney disease. So today I'm going to focus primarily on issues related to dialysis. I should say that I am a card-carrying nephrologist. I'm not trained in geriatrics or ethics or palliative care, but these are issues that we as nephrologists face every day, and I think it's important that everybody in the healthcare community be on the same page. Nothing to disclose. So the boomers are coming. In fact, we are already here. So as you all know, the population is aging. There are more and more of us old-timers around all the time. And with the aging of the population comes an increase in the burden of diseases that are disproportionately represented in the older population, such as heart failure, such as dementia, and chronic kidney disease. And this is data from the CDC that shows just that. It's estimated in this country that perhaps 15% of people have chronic kidney disease, but as you can see in the purple bars, that really goes up with aging. So middle-aged folks have a higher rate than younger folks, but once you get to people over the age of 65, it's estimated that 40 or 50% of the population may be affected. So it's very busy. So I'm going to frame this conversation with this patient in mind. This is an older woman with chronic kidney disease. She's an 84-year-old Caucasian female with hypertension, type 2 diabetes, and atrial fib. Her medications are lisinopril, metoprolol, glipizide, and warfarin. Her blood pressure is 146/62, and her creatinine is 1.2, which calculates out to a GFR of 45, which is so-called CKD stage 3A. It's been stable for several years, and she is a non-proteinuric. So we've known for a long time that, like everything else, renal function declines with age. And this was a classic, beautiful piece of clinical research published by Davies and Schock in the JCI in 1950. So they measured a GFR by inulin clearance and renal plasma flow by diadras clearance, the hard way, actually injecting stuff into people, and showed that with age, when they going from a age of 20 on the left over to 80, there was a progressive decline. It was variable, but it's there. And they said back in 1950, although a number of alternative hypotheses have been advanced, we do not yet have the crucial data to decide what mechanisms are involved in this process. And I would submit that we are learning more about this all the time. And I think a big clue was presented back in the 1600s by Dr. Thomas Sydenham, who said, a man is as old as his arteries. So I think the kidneys are the canary in the coal mine of the cardiovascular system. And there's no question that aging of the vasculature contributes to chronic kidney disease. And in fact, there was an interesting paper published a few years ago looking at risk factors for having your creatinine go up as you get older. And these look for all the world like standard cardiovascular risk factors. Older age, diabetes, hypertension, smoking, having a high LDL was somewhat protective. So there seems to be a theme here. And in addition to atherosclerotic type small vessel changes, there are other changes that occur in the microvessels in the kidney. So in the juxtamedullary region, you can actually have formation of direct channels between the afferent and efferent arterioles so that the glomeruli just sort of fall off and you end up with these aglomerular arterioles. Tim Meyer and others have more recently shown that this occurs in some other renal diseases as well. In the cortex, you're more likely to have atrophy of both the afferent and efferent arterioles, and that can lead to global sclerosis. There's also an increase in the interstitial volume in the aging kidney, more tubulointerstitial fibrosis. This shows the increase in volume with aging. And there are a number of mediators that have been identified as potentially contributing to this. These include increased activity or responsiveness to mediators which are both vasoconstrictors and pro-proliferative, such as the renin-angiotensin system, decreased activity or responsiveness to anti-proliferative vasodilator mediators like nitric oxide. There's an increase in expression of fibrosing mediators, increase in oxidative stress, and increased apoptosis. And there's also loss of peritubular capillaries. So I want to show you a study that was a product of a collaboration between my lab and Rick Johnson's lab a number of years ago now, where we looked at capillary density in aging kidneys, in this case, a rat model. So if you look on the left side of the pictographs, you can see that the young rats had very nice glomerular capillary architecture and very nice fine architecture of the peritubular capillaries, whereas the aging rats on the right are kind of losing both. And the aging rats had increased rarefaction and decreased capillary loops. So this is one of the many mechanisms that we now recognize contribute to the age-related loss of GFR. So, and as I said, there are now a number of mechanisms. This was from a review article published a couple of years ago that in addition to hypertension, increased renin-angiotensin activity, increased activity of transforming growth factor, there's oxidative stress, there's acute kidney injury. I'll talk more about that. So a lot of things that happen as we get older actually may play a role in the age-related loss of renal function. So back to Our Lady. This is the era of precision medicine. Now, I would like to contrast our patient, and we'll talk about her prognosis, versus the other patient. So this is an 85-year-old Caucasian female with a GFR of 45, and on the right is a 35-year-old African-American male with a GFR of 45. They both have the same GFR. The prognosis is very, very different. It's different because of their age, it's different because of their gender, and it's different because of their ethnicity. So let's talk about Our Lady. It turns out, and this was an interesting study that Hare published a few years ago, an older patient with chronic kidney disease is actually more likely to die, probably of cardiovascular disease, than to ever go to dialysis. So she looked at the age at which, at the GFR below which you're likely to go on dialysis before you get very old. And for young people, that GFR was around 45. So if you're 20 years old and your GFR has already declined to 45, chances are pretty good that you're going to go on dialysis before you get a lot older. So contrast that to the far right, those aged 85 to 100, that level drops to 15. In other words, an older patient needs to have their GFR decline all the way down to 15 before you can say, yeah, it's pretty likely you're going to go on dialysis. So that's, I think, a very important way to think about it as we try to estimate the prognosis for our patients. And in fact, there is a prognostic tool you can use. This is from QXMD. I have absolutely no connection with this company. I have no financial interest in this. It's an app you can download, but you can look at a specific patient and enter their age, gender, GFR, a few other things, and it will give you a prediction of how that patient is going to do. And in this patient, my 84-year-old patient with a GFR of 45, non-proteinuric, her risk of progressing on to dialysis is actually very low, about 0.4% over 2 years, maybe 1.4% over 5 years. So, it's a pretty good prognosis if nothing else happens. But if nothing else happens, this would be the shortest grand rounds in history. So, of course, something is going to happen to her. So there are a lot of questions about early CKD and what we're doing with our patients. The question has arisen, will the diagnosis and treatment of early chronic kidney disease in older people confer any benefit? Can we do anything about their survival or their heart disease or their kidney disease? And do the benefits exceed the harms of diagnosis and treatment? So Dr. Moynihan has been publishing a lot about this and using the argument that overdiagnosis and overtreatment can really cause harm. So what these summary points say, and I'll read them to you, are that overdiagnosis and related overtreatment are increasingly recognized as a major problem. And you've heard some of these controversies with early breast cancer, et cetera. Positive average results from the risks of treatment, from trials of treatment, can mask situations where many participants at low risk of disease may receive no benefit. And there was a study done in patients with an analysis done of the data to look what would happen with older patients and ACE inhibitors. We know that young patients who have proteinuric diabetic nephropathy have a very strong likelihood of benefiting from ACE inhibitor treatment. Older patients who don't have proteinuria, not really. So that's a perfect example of that. The evaluation of diagnostic tests usually involves assessing how well tests detect presence versus absence of disease, not how well they detect clinically meaningful stages of disease, and changes to disease definitions typically do not involve evaluation of potential harms of overdiagnosis, and, by the way, are often conducted by heavily conflicted panels. So more closely applicable to chronic kidney disease, the same Dr. Moynihan and Dr. Glassick, who is a noted nephrologist, who is a previous Schreier lecturer, wrote this paper, how expanding definitions are unnecessarily labeling many patients as diseased. And they asked the question, why is less than 60 considered abnormal at all ages? A GFR under 60 may, in fact, be quite low for a 30-year-old, but not really an 80-year-old. 3/4 of patients with CKD... Okay. Okay. My screen just went down. Yours didn't. 3/4 of patients with CKD3A have no albuminuria. And we know that proteinuria is a big risk factor for progression of kidney disease, and lack of proteinuria is a good sign. And they just wonder if this is really a disease or medicalization of the normal aging process. Okay, so she develops hip pain for which she takes naproxen, and when she's seen by her primary care provider, her creatinine is now up to 2.2. So now we have a problem with those aging renal vessels. So in addition to problems with small vessel disease of all the vessels in the kidney, there are problems with the glomeruli. And so patients who have intrinsic small vessel disease may be super sensitive to perturbations. This was from one of my favorite papers, published by Gary Abuelo some years ago now in the New England Journal. And he made the point that you can get ischemic acute renal failure without having overt hypotension. So this shows a normal autoregulation curve going from the right, a normal blood pressure. Most of us can drop our blood pressure quite a bit, and the kidney can autoregulate and keep GFR okay, and then we sort of fall off a cliff. There are others, however, who cannot autoregulate nearly as well and are prone to developing even normotensive acute renal failure at a higher level of GFR. And that same article had some beautiful pictures that kind of explained that. So the glomerular capillary network is unique in the body in that it sits between two resistance vessels, the afferent and efferent arterioles. So what happens when you drop your renal perfusion pressure, is shown on the right here, the first thing that happens is you have a spurting out of vasodilatory prostaglandins. And what those do is they dilate the afferent arteriole to try and allow an increase in renal blood flow. And as blood pressure goes further down, the next step is that there's a constriction of the efferent arteriole under the influence of angiotensin II, and that allows your glomerular capillary pressure to go up, again trying to maintain GFR. Well, if you're on a non-steroidal, you can't dilate the afferent arteriole. So that first step is obviated. And if you're on an ACE inhibitor, you can't constrict the efferent arteriole, so that's gone too. So this is a beautiful example of why an older person whose vasculature isn't that great anyway, on an ACE inhibitor and on a non-steroidal cannot maintain their GFR. And there's a lot of other reasons why older patients are susceptible to acute kidney injury. I already mentioned some of the age-related functional changes. They have a fall in the ultrafiltration coefficient, lots of structural changes. Chronic comorbidities, particularly cardiovascular disease, contribute. And all the things we do to our patients, ACE inhibitors and ARBs and contrast and everything else. There are other factors. There's an increase in stress-induced cellular senescence, chronic inflammation, oxidative stress, etc. So older people really are susceptible to acute kidney injury. So what is her prognosis? We now know that there's an interplay between acute kidney injury and chronic kidney disease, and acute kidney injury is a risk factor for subsequent development of chronic kidney disease. And how likely that is to occur and how bad it's going to be depends on a number of things, disease modifiers. The severity of the acute kidney injury, if you have dialysis requiring acute kidney injury, you have a much worse prognosis than if not. The stage of chronic kidney disease you started with, the number of episodes of AKI, and the duration of primary injury, et cetera. So this episode of AKI that she's having now is a risk factor for her. So recently, a group published sort of a consensus document on this interplay between acute and chronic kidney disease. And they introduced a concept, which I will just tell you about, which they called acute kidney disease. And what they pointed out is this is sort of a continuum. And for their purposes, they sort of defined acute kidney injury as something that lasts up to about a week. If it then goes on for up to 90 days, they're calling it acute kidney disease. And then after that, chronic kidney disease. I'm not sure those labels are important, but they made the point that many different things can happen. So, and don't worry about the stages or anything else here, but this is sort of what can happen after acute kidney injury. So in the purple here, a patient can have a bad episode of acute kidney injury and then it all gets better and they're just fine. In this green line, that gets really bad and it gets better, but it never quite gets back to baseline, but it gets a little better over time, looking at the GFR. This patient, you know, it's not that bad to start with, but it just goes worse and worse and worse. So the point is that the pattern of what happens to kidney function after an episode of acute kidney injury is variable and can do almost anything. Others have tried to look at this more quantitatively. This was a study where they looked at 100% of hospitalized veterans throughout the country in the year 2011, patients who had a baseline GFR over 60, so we would consider normal. And the column here on the left is patients with the mildest stage of acute renal failure, and they kind of looked at the chances of developing stage 3 chronic kidney disease depending on how long, what their recovery pattern was. So those patients who had acute kidney failure for about 2 days had a little bit of a risk, but if it was still elevated over 10 days, the risk was higher. And over here, worse kidney injury was higher. Albuminuria also played a role. But the point is that even the mildest stage of acute kidney injury can increase your risk of developing subsequent chronic kidney disease. And here's a graphic example. This is a patient I saw a few years ago. This was a middle-aged woman who had cardiorenal syndrome. So as you might predict, she would get fluid overloaded, her cardiac output would fall, she'd get acute renal failure, she'd come in the hospital, she'd get diuresed, then she'd get over-diuresed, and she'd get acute renal failure. And when you see this sawtooth pattern of creatinine In my experience, that's usually cardiorenal syndrome. So she started out with a creatinine of about 1.2 or 3, which was not really normal for her age. You know, creatinine bumped up to 1.5, sort of came down. The next time went up to 3.2, et cetera, et cetera. And you can just get a sense that, first of all, she's never going to come back to 1.2 again. And if she continues this, she's going to go on and need dialysis. So a graphic example that recurrent episodes of acute kidney injury set up a bad prognosis for the kidney. And this has been documented many ways. This was a study that looked at over 500,000 Kaiser patients who started out with a baseline GFR over 45, so not bad. And they found that if they had an episode of acute kidney injury requiring dialysis in the hospital, that was independently associated with a 28-fold risk of developing stage 4 to 5 chronic kidney disease and doubling of the risk of death. And this stuff is important for all of us to know, because you know that patients and their families ask us all the time what's going to happen. And we have to say, usually, we don't know for sure, but we can't promise the kidneys are going to get better. And it makes sense. There's some common mechanisms. This is from a recent paper by Joe Bonventri's group that sort of talks about these maladaptive kidney repair mechanisms that jump into play when you're trying to recover from acute renal failure. And this is aging. And a lot of these things are very similar. Altered growth stimulators, microinflammatory disease, tubular loss, et cetera, et cetera. So the point is that especially an older patient who's got age-related kidney disease and then has an episode of acute renal failure that's going to stimulate some of those same adverse mediators may not do well. So back to our patient. Her ACE inhibitor is stopped and her non-steroidals are stopped. And her serum creatinine settles out at about 1.8, so higher than her baseline, which gives her a GFR of 22. That's stage 4. She's referred to a nephrologist, which is appropriate. We like to see patients when they get to stage 4. A brief discussion introduces the topic of dialysis with a plan to further explore the goals of care in subsequent visits. Full disclosure, this is what I do. You know, at best, I have 5 minutes at the end of the meeting to say, by the way, do you know anything about dialysis? We'll talk about it later. So in the Choosing Wisely campaign, one of the important recommendations that the ASN put forward was that you don't initiate chronic dialysis without ensuring a shared decision-making process between patients, their families, and their physicians. And you can say, well, duh. But guess what? It's not that simple. Talking about dialysis is like talking about cancer. Patients and their families would prefer not to think about it and wish it would go away. They will frequently, on the second visit, when you say, do you remember we talked about dialysis last time? They will say no. That's denial. Providers would prefer not to talk about it. The discussions are difficult. But the patients actually want the information. They expect their physicians to initiate the conversation, and they want to know their options. So it becomes challenging. I think that we as a profession are not as good as we should be about advanced directives anyway. And in terms of advanced care planning in patients with kidney disease, whose job is it anyway? Is it my job as a nephrologist? Is it your job as the primary care provider? And it's difficult to read what's in these boxes, but it's kind of echoed on the next slide, which sort of discussed the same topic. They looked at specialists and primary care providers' views on barriers to adequate preparation of patients for dialysis. They commented there's poor integration of primary and renal care, patients' low perceived urgency of the preparation for dialysis, their fear of dialysis, cultural beliefs, language barriers, lack of trust, variations in provider insight. Some primary care providers are more comfortable talking about dialysis than others. So the net result often is this: subsequent discussions are inconclusive. Have you thought any more about dialysis? Well, a little bit. Any decisions? Nope. And so over the next year, her renal function declines to stage 5. It's time to make a decision. So now we get into some ethical issues, and there's been in the last couple years a lot of these articles coming out about the ethics of whether we should dialyze grandma. Dialysis in the frail elderly, a current ethical problem, an impending ethical crisis. The ethics of chronic dialysis, it's time to reevaluate the norms. Practice change is needed for dialysis decision making. So it turns out that in the elderly, especially the frail elderly, dialysis is not a panacea. The overall benefit is actually very modest at best. And when you think about what people articulate as their goals of care, so what do you want your treatment to accomplish for you? How does dialysis do? They want to be cured. Not going to happen. Live longer. Probably not. Improve or maintain function and quality of life and independence? Probably not. Be comfortable? No, it's not comfortable. Achieve life goals? Well, maybe. Maybe if a patient has a specific desire to live 6 more months for some event, maybe. Provide support for the family and caregiver? Yes or no. So it's not really clear that if the patient can articulate his or her goals of care, that dialysis is going to help with any of this stuff. And we do kind of a terrible job. This was a study that looked at the entire VA database for a decade or so. They found 29,000 veterans with a GFR less than 15, stage 5, and they looked at whether they were already on dialysis, they were at least thinking about or preparing for dialysis, or they had decided against dialysis. And they looked by age groups. So the ages are less than 65, 65 to 74, and over 75. So the far right are those who had decided against dialysis, and probably appropriately, the patients who were over 75 were much more likely to have decided they're not going to do dialysis than younger people. But still, they looked at, by age group, what was happening. And over here, the far right, are those over the age of 85. So the various gray and black bars, which represents 50% of the patients over 85, were either on dialysis or preparing for dialysis. Half of them had decided not to. That's a lot of older people going on dialysis, and it contrasts greatly with other countries. So they showed data from Canada, so U.S. is in the black bars, maybe appropriately. Canada is in the gray bars, and Australia and New Zealand are in the white bars, and they look at the number of patients on dialysis by age. And if you look over toward the right, the numbers are not too different in the younger groups, but those 75 to 84 and over 85, we are dialyzing a whole lot more people than our colleagues in Canada and Austria and New Zealand. And Australia and New Zealand. It seems to me that our medical practices are probably similar. Access to care is probably similar. It's not like Canadians can't get dialysis, I don't think. So, so we're doing something differently, and I'm just wondering if we're doing the right thing. We do a terrible job in advanced care planning. Many of our patients don't have advanced care directives. Advanced care directives almost never mention dialysis. I have an advanced care directive. The word dialysis is not on there. And our dialysis patients who are at serious risk for getting sick, being hospitalized and stuff, often don't have advanced directives. And in fact, Sarah Combs here at Colorado has written about this. Once patients go on dialysis, especially the frail elderly, they do terribly. So I'll show you a couple of slides that I think are horrifying data that we should all think about. This one, this paper looked at all U.S. nursing home residents who started dialysis over a 2-year period. So these patients were already in a nursing home. By 3 months, about a third of them were dead, about a third of them had decreased functional status, and about a third, or 40%, had at least maintained their functional status. By 6 months, half of them were dead, and fewer of them were functional. Worse at 9 months, and by a year, 2/3 of them were dead, and a very, very small fraction of them were able to maintain their functional status. So what I'm getting at, obviously, is it's really important for us to do our best to give patients and their families realistic expectation of what's going to happen with dialysis. And we do a terrible job in the final month of life. This compares what happens to cancer patients and heart failure patients, and these are extant dialysis patients. Sadly, our patients in their final month of life are far more likely to be in the hospital, to be in the ICU, to have intensive procedures, far less likely to be on hospice, and much more likely to die in a hospital. So we really need to do better about this. So for our patient, how's she going to do? So there's another risk app, same app, that looks at the 6-month mortality on dialysis. So you can enter, if you want to guess how your patient's going to do, you can enter age, albumin, dementia, peripheral vascular disease, and the famous surprise question. Would I be surprised if this patient died in the next year? And that has been validated. So what if the patient decides not to do dialysis? Well, you know, it may be okay. This was an interesting graph that Jean Hawley published looking at the illness trajectories over the end of life with various diseases. So colon cancer patients can do quite well, and then they kind of fall off a cliff. Patients with chronic diseases, including heart failure, COPD, and end-stage renal disease on dialysis, kind of decline over time with some sort of ups and downs. Those who are frail and demented start pretty low and just kind of go down. But in the red, those patients who are CKD stage 5, GFR less than 15, and don't do dialysis sometimes can live a very reasonable quality of life and maintain a reasonable quality of functional status until the end. So worth thinking about. So, of course, our patient doesn't have that luxury. She's admitted to the MICU with pneumonia, sepsis, and oligoanuric acute renal failure. The MICU team tells the patient and family that she needs dialysis. We'll call nephrology. We hate it when you do that. So can you please not set us up that way? It sets us up to be the bad guy when we have to come in and say, no, dialysis won't help. And also, I think it can... Again, it can start to set up unrealistic expectations that if we just put the patient on a dialysis machine, she'll be able to come off the vent and walk out of the hospital. So what will be the outcome if we dialyze her? Well, as you know, there's a lot of literature that basically being in the ICU is not very good for old people. This was a paper, for example, published in JAMA Internal Medicine that looked at functional trajectories among older persons before and after critical illness. And the bottom line was more than half of them died within a month or experienced significant functional decline during the following year, with particularly poor outcomes in those who had high levels of premorbid disability. So, you know, again, this relates to we need to be more conscious and conscientious when we're trying to describe prognosis and goals of care in our elderly patients. And what about chances of getting kidney function back? This was a study of a large number of patients, not all elderly, that looked at those patients who started dialysis in the hospital, how many were able to come off dialysis later. And we get that question asked all the time. And the answer is like not very many. In this study, about 20% were able to come off dialysis after 15 months. And your chances were even lower if you were on the right side of the screen, if you had a low GFR to start with, and also heart failure was a predictor. Interestingly, in this group, heart failure increased your chances a little bit, but in most of the groups, having heart failure was worse. So it's not super realistic, I think, to tell any patient, yeah, you're going to come off dialysis. Sure, if it's a young person who started out with very healthy kidneys, and it seems to be a time-limited illness, there's hope. In other patients, not so much. In fact, Woody Moss has written a paper about the ethics of offering dialysis for acute renal failure to the older patient. He points out that a major consequence of the biomedicalization of aging is the relatively unquestioned provision of dialysis for AKI. Nephrologists should not automatically recommend dialysis for these patients, and those who can be predicted to do poorly, recommending against dialysis actually upholds the Hippocratic maxim and to be a benefit and do no harm. And so he challenges the automatic transformation of the technological imperative into the moral imperative for such patients. We really have to think harder and smarter about these patients. So after discussions in this patient, after discussions with everybody, including the palliative care team, who I think should be brought in really early in these discussions, she was transitioned to comfort care and passed away peacefully. So medicine is changing, and there are a lot of forces coming into play here. If you Google V2V, what comes up is vehicle to vehicle. But I really want to talk about the transition from volume to value. Right now, if I dialyze a patient, I get paid more than if I advise them not to take dialysis. And the hospital gets a lot more money if I dialyze that ICU patient than if we talk to patient and family out of dialysis. So this is this tension between our current fee-for-service system and the value-based care system we want to get to is everywhere. Dialysis is just one of them. You know, I can hope that maybe in this case, when it comes to the dilemma of whether we should dialyze grandma, maybe in the coming years it will become a little more clear, at least financially to the hospital, that we should do the right thing. I'll leave you with this, that first we should do no harm. And finally, this is the view. OHSU, where I work, sits on a hill overlooking the beautiful city of Portland. This is Mount Hood. At the bottom of the screen or below the screen is the waterfront where we have a clinical tower, and this silver gondola thing takes us up and down. So if you ever happen to come to Portland, we call it the tram. Come take a ride on the tram. It'll be well worth your $4. Thank you very much. If you can find me, I'll give you a free tram ticket.
Thanks very much. That was a very interesting talk. Let me just ask a quick question, then we can open it up to question. How do you pick out the grandma or grandpa that would benefit from dialysis?
Yeah, that's a great question. How do you figure out which older person would benefit? It has a whole lot to do with their baseline functional status. You know, how the oncologists use their Karnofsky scores. I don't do anything that formal, but a patient who's robust and still active and wants to continue his or her life can do it. You know, we have a 92-year-old in our dialysis unit who goes bowling 3 times a week. Well, if he can do that, he's probably going to do well. Whereas the more comorbidities you add on and the more frailty, the less likely they're going to do. I don't know a good scoring system, but I think that's the mental framework that we all use to try and decide what to advise.
Questions from trainees or? Okay, hold on. Wait until we give you the microphone.
Can't hear you.
I've noticed that most advanced directives across the country do not have withholding dialysis as an option or a discussion. Have you found the same thing?
I didn't quite get the question. Patient.
Most advanced directives or living wills do not have the option of choosing whether to withhold dialysis or not.
So I've never seen an advanced directive form that does have dialysis as an option. Do you have one? Yeah. And we have a post form. You know, Oregon's way in the forefront on the post forms and stuff. It's not there either. And maybe it should be added. Is it less likely than the feeding tube question? Sure. But especially in a patient like that. So thank you. I'll see if I can bring that in. Is Sarah Combs here? She may be watching somewhere at the VA. Okay. She's written about it, so we'll get her involved as well. She's published on this stuff.
Other questions? Isaac?
Sharon, as a major proponent of peritoneal dialysis, which, as you know, can be performed in the comfort of one's home and, if necessary, with a family member assisting. It's my impression, I don't have data, but it's my impression that grandma will do better on peritoneal dialysis than she will on hemo. Is there data?
Yeah, so the question is, would grandma do better on peritoneal dialysis, which can be done at home, doesn't require 3 times a week to the dialysis unit, is gentler on the cardiovascular system? Absolutely. Would she do better? I think so. I don't know of any data, and it seems that hopefully somebody must have looked at that in the frail elderly, but it makes sense. And I thank you for bringing that up, because it is an option that sometimes I am even more careful to bring up and introduce to the family. In younger people, we sort of prefer it if the person can take responsibility for their own. But in an older person, if there's a caregiver who can do it, it can be a real good option. So thanks for bringing that up. And I'll have to look and see if there's data. None springs to mind, but.
Are there any data that talk about the relationship of withdrawing from dialysis as a function of age?
That talk about what?
Withdrawing from dialysis.
Withdrawing from dialysis. Yes, that's extremely important. So every time I talk to patients about dialysis, I remind them it's their decision whether to start, when to stop. If they start and then they decide they want to stop, that's their decision. I often encourage a time-limited trial. If they're on the fence, I say, look, why don't we do this? You commit to doing it for 2 months, and then you can decide. So in terms of withdrawal from dialysis, there's no question that the rates of withdrawal from dialysis are much higher in older patients, much, much higher, which to me goes back to the wisdom of should we have started them in the first place. But the rates are much higher.
Question in the back.
In terms of patients that choose not to go with dialysis, do you have a good model in terms of transitioning from palliative care or hospice, or when to start initiating those services, kind of when we see the decline with kind of
So
functional
I think the
status?
question was, if she decides not to go on dialysis, what about hospice and palliative care? Is that sort of what you're asking?
Just kind of timeline for patients of what to expect
So
and when
it's hard to know. So if we know if a patient is if they're so far advanced they're not making any urine, you can say pretty confidently you'll probably live another 10 to 14 days. If they're still making urine, I've got patients in stage 5 who, a year and a half later are still doing fine. So it's hard to know when to call in hospice and palliative care. I think it's really important to have patients be aware that that's an option anytime. I've had patients where the well-meaning primary care provider puts a patient on hospice, and 6 months later, the creatinine's still 4, and they get kicked out of hospice because they've gone past 6 months. There is a movement in nephrology called supportive care nephrology, which is really nice. And this is really the art and science of doing everything we can to perpetuate the best possible, not just quantity, but especially quality of life for these patients. It brings in all the best practices of hospice and palliative care, maybe not the terminal morphine, but everything else. And another thing I'm not expert in, but I'm really excited about that, because there is evidence that if we sort of do that right, then patients can have, again, if not much longer to live, at least a better quality of life. So it's a really exciting movement in nephrology that's really taken off over the past couple years, and I think we will hear more about it, and some of us will get more educated, and we'll see. People actually have supportive care clinics. We're not there yet, but I think that's a great goal.
Larry?
Hi, Sharon. Enjoy your talk. Has grandma been being considered for a kidney transplant? We have a lot of pretty senior patients coming in with that kind of decisions, and certainly it's not fair to put everybody on a transplant list. But what happens if they have one of their family members who willing to step forward and being considered?
So I think that your question related to generally the advisability of putting people on a transplant list. So transplant people, I think, are much more rigorous than we dialysis people are, because, if the patient I think the transplant docs are much better at prognosticating whether the patient will live long enough to benefit from a kidney, and if not, the answer is no. We don't go through anywhere near as rigorous a process, in my opinion, before we put people on dialysis. So I don't think the transplant thing is broken. I also, at our center, we don't technically have an upper age limit for kidney transplants. Patients who are in their 70s anyway and are robust and active and don't have bad heart disease and all that kind of stuff can be considered for transplant. But it's not going to be the answer, unfortunately, for the frail elderly that I'm worried about.
All right. Well, thank you very much. Thank you. And we have a plaque for you, Sharon, from the division, on behalf of the Division of Nephrology and the Department of Medicine for the Robert Schreier Lectureship
how nice.
2017. Let's give her a hand.
Thank you. Thank you very much.
Great talk.
I had some points I wanted to get across, and I hope I did.
You did.
My feeling was this is a general medicine audience. I'm not going to say much in the phone. I just don't know, but they're not the ones I'm talking to.
It's a great talk.
Yeah.
Thank you.
Great talk. Thank you.
And
So
Nedra Moore. How nice to see you. Yeah.
Wonderful talk.
Oh, thank you. Thank
Also,
you.
I'm so proud of your multiple leadership roles.
It's great for the
Chair of the Department of Medicine.
I know.
That's the last one. I'm not going.